Okay, yeah, page 20 of your notes. Now, you all know that while I talk to you, I record this for my virtual class too, because I think it's important that they at least hear someone speak instead of me just saying, read this PowerPoint. I don't feel like that's as helpful. Maybe they probably don't even listen to me. They're probably just fast forward me. I don't know, but I need someone that is okay with people seeing them, okay, because I have to put this on YouTube. With someone seeing them, because I need to demonstrate range of motion to them and you. Okay. So if somebody's like, oh, I can do that, I need like a mock patient here in a second. Okay. Did you raise your hand?
Yeah, I'll do it. Okay.
And then Abby. So one or the other. It doesn't matter. Okay. And I don't care either way. Okay. So let's talk about what range of motion means first. The biggest part is learning all the moves. What is the difference between atrophy and a contracture?
Okay, the contracture stays right there.
Right. It's permanently flexed.
Yeah. And
okay.
Atrophy is decreased in size.
Right. And they're both caused by what? Yeah, like a movement of that joint. So we're going to talk about range of motion, and we're going to talk about how we can avoid atrophy and contractures and all those other things that go along with it. So why we perform range of motion exercises in rehab. I said yesterday, if you don't use it, and that's exactly why, okay? If we don't let those people move those joints, then they're going to stiffen, they're going to atrophy, contracture, all of that. There are some other things that happen as a result of not being mobile. So if you think of some situations when people are not mobile, surgery, okay, that puts you down for a little bit. Just age itself, dementia, all of those things. And when I say not mobile, I don't mean like you have the flu and you're sick for 2 days, and you're not out of bed. I mean more like you had surgery and then you're in pain and then you're stiff and you're afraid to move and you just decide to lay in the bed and never get up, never reposition yourself. That's more what I'm talking about. Range of motion is done to maintain the health of the musculoskeletal system. So problems caused by immobility, here they are. Contracture, atrophy, stiff joints, circulatory impairment, meaning blood clots. Hopefully by now you understand that if blood clots and that clot is going to block blood flow to a certain area, if a certain area of the body doesn't get blood flow, what's going to happen? Right, it dies, okay? That clot could also fly off and go to the brain or the heart, have a stroke, heart attack. So as people lay in the bed and they're not mobile, they're not moving those extremities, that blood, it just kind of sits there. It doesn't move as fast. And if anything just sits, something like blood just kind of sits and isn't moving, it coagulates, it clots, okay? So very high risk for people after surgery to develop a blood clot. Mineral loss, our bones store calcium. The more we lay, the more we don't move, the more calcium we lose out of that bone. Respiratory problems, we talked yesterday about why someone would have respiratory problems if they were in the bed. Do you remember why? What can you not do as well?
You can't cough up.
Okay, so coughing and then fully expanding your chest is done right. You can't fully expand laying down, but you can fully expand more sitting up. So all that gunk gets in there and they can't get it out and you get some pneumonia. Bladder infections, constipation, poor appetite. Basically everything kind of slows down the less that you move, okay? So we want to prevent those problems. This is an x-ray of a contracture. Do you see that? Look at that. That's right at the carpal bone, the wrist, and look how flexed that is. I mean, that is painful.
And that, it looks like it's bent at the bottom, too.
It does. It does. It really does look like and I don't know, I'm not an x-ray tech or a radiologist, but that just does not look fun. You see this a lot in older adults, especially in nursing homes. If you look, you'll see that like sometimes like their fingers will get contracted.
Oh, I have a
It's just
question.
not good.
Is it true, like, if you don't move your joint for a long time, like, if you injured it, like, when I broke my elbow, they got me out of my cast after 3 weeks because they were afraid that my joint would fuse to itself? Is that like an
Yeah,
actual
that
thing?
could happen. You can also get what's called like frozen joint, where it's so stiff from not moving it, they have to go in and move it. You get scar tissue there. Yeah. Um, this, we're going to talk a whole lot more about stroke, but this is the idea of like, so if we had a clot, let's say in our lower leg, and it broke off, it could fly up here to one of the arteries in the brain. And you see this right here, this is all the tissue death of the brain caused by that clot that's blocking blood flow. So we don't want any of those things to happen. Why would a respiratory infection be prevalent in patients that are immobile? Again, they can't fully expand their chest. Getting up moves those secretions more. It breaks up those things more. Think about most of the people that you're going to see in a rehab setting, like a nursing home, are older. And if they're younger, they have some sort of chronic problem. Most of them have like COPD, heart disease, diabetes. So they're going to have those initial problems anyway. So you have to be very proactive with them. My hope is that somebody, at least one person in this room, will go take care of older people. Not to say that there's not any credit in like taking care of kids. Absolutely. I'm very thankful for children's, but it seems to me that a whole lot of people don't want to deal with the older adult generation. They want to deal more with like, everybody wants to go to the ER, which is very important, totally important. But I think that's why our nursing home patients don't get as good care as they deserve. They just don't have enough. They don't have enough people. And I know it's not like super like healthcare is not glamorous anyway, but I mean, I know it's not like the first place. I mean, they do smell weird, and I mean, they do have an odor, and there are a lot of things that you have to do as a healthcare provider that maybe you wouldn't have to do as much in the hospital. I mean, I can see why it wouldn't be a new graduate nurse's first, but actually they actually pay really good just because of the demand. So I don't know,
How
but
would you deal with
anyway.
them dying all the time?
Yeah, and it's just like it's a chronic thing. They're chronically there. They're going to be there for a long time. Your patients more. So I don't know, just maybe.
My aunt works at one of them. I think she's like it's not like the manager, it's like the nursing, she commands.
Like a nursing manager, supervisor,
something like
team
that,
leader.
It's not, yeah.
Yeah.
At the morning one.
Yeah, that's a good one. Anyway, so we have 4 different types of range of motion that we could do on a patient. Active means the patient does it all themselves. So I show them the movement and they do it. Okay, they are actively doing it. So I think in your notes that's one of the boxes. So active is patient does themselves. So you actually have to fill in something here. But patient does it themselves. Okay, so if active is doing it themselves, what do you think active assistive means? Yeah, they're active to the point where they can't do it, and then the therapist helps them finish that movement. So independent, partly independent, it's like half and half.
So which we say patient needs help.
Yeah, patient does most and therapist helps.
Okay.
So a good example of this one would be someone right after surgery. They would move to the extent that they can, and then the therapist kind of has to help them. What do you think passive is?
They can't move at all.
They don't do it at all. The therapist does it all. So someone with paralysis, that would be a really good example. They can't move it. And then the last one is resistive. And this is administered by therapists, and they provide resistance. So a really good example is, I'm sure, to test your strength, they'd say, hold your arms up, and then they'll say, okay, I'm going to push down, and I want you to resist me pushing down on your arm. Okay, so they're providing resistance, but they're also doing range of motion. So providing resistance, I guess, is the best way to kind of understand that one. So, as with everything else, we need to talk about safety. Safety as far as things to remember for these people. First of all, a doctor, the surgeon, the orthopedic surgeon that did the procedure, will tell you what degree. Again, there's that math again, that geometry, and we'll talk about how to tell that later on, but they'll say they can do flexion to 30 degrees and then we have to stop, okay? They're going to give you limitations, because if we go beyond those limitations, then we probably hurt that surgical site that they just repaired. Movement should be slow, smooth, and gentle. So in other words, you're not like moving the head around like this. When I teach you all this every single time, you all are like moving the head around, and you're going to give your poor partner a concussion. It's terrible. I'm not going to force a joint. If the patient complains of pain, I'm going to stop. Remember, I told you yesterday, pain is very subjective. We kind of have to take their word on it. Typically, each movement we do 3 to 5 times or as ordered. So we're not just going to really do it once. So if we're working on the shoulder, we're going to do all of those movements about 3 to 5 times. I want to encourage the patient to help as much as they can, because they need to be doing the work. Some states, and I don't know about Tennessee, in some states, only a nurse or a physical therapist can do range of motion of the neck area. I don't know. Who could do range of motion? Really, any healthcare provider that's trained. So when I worked in the ICU, when I was in nursing school, I would go in and do range of motion on patients who were on ventilators, because they weren't moving, right? But they needed to move those joints. So we go around and move their wrists around. I mean, anybody can do it as long as you know what you're doing. I wouldn't say, just move the joint wherever. But anyone can do it. But again, think about those orthopedic surgeries, though. Hip replacement, shoulder replacement, there's only going to be certain ways that they can move that joint for a while until the orthopedist or the physical therapist says, oh, you can move it a little further. Who writes the orders as far as their exercise plan after surgery? Who writes those orders? So the surgeon initially, and he'll refer them, he or she will refer them to physical therapy. The physical therapist is the one that will evaluate them. And based on that evaluation, they will set out like what sort of exercises and equipment they need to use. When you're looking at career-wise, what you want to do, a physical therapist is more the initial assessment, and they order the exercise plan. That's why they have to go to school longer. A physical therapy assistant Any of you who've ever been to PT, most of the time, the people who are giving you ice and doing your exercises, most of the time, they're the physical therapy assistant. They go to school for about 4 years compared to 8. Same thing with an OT. They look at finer muscle movements like grabbing things, grabbing a fork, brushing your hair. They're going to do the initial assessment and then make a plan based on that. And the OTA, occupational therapy assistant, would carry out those plans. You do also have a chiropractor who also works with the musculoskeletal system. Do you remember how many years they have to go to school? Yeah, they have to have a doctorate degree. They have to go to chiropractic school. So, and they have a different approach. So, but a lot of times physical therapy is really very much incorporated into chiropractic care. So, but that's that. So, we've got to learn some terms before we can do range of motion. So we're going to do range of motion from head to toe, but we need to talk about these terms. So, abduction, abduction. You should know that from health science and anatomy. If you abduct something, what are you doing? You're taking it away. So abduction is away. If I did shoulder abduction, what do you think that would look like? So abduction. Shoulder adduction, AD, back toward the middle of the body, back toward the body, okay? Those are easy. Flexion. Flexion is bending a body part. That one's easy. Sometimes you'll hear it called decreasing an angle. I am not a math person or good at math, but okay, so I do know that those of you who've had geometry, a straight line, what angle is that? 180. If I flex it, does the degree of my angle go up or down?
Goes down.
It goes down, so decreasing the angle. Extension is increasing or extending a body part. Hyperextension, excessive straightening of a body part. We don't do hyperextension on every joint, but there's an example of one. Rotation, moving on its own axis. If I said rotation of the head, what do you think that would look like? So not in a circle. So an axis is like your planes of motion. So you want to stay in the same direction. So actually rotation would be moving like this, okay? Moving from side to side. Circumduction, that means circle. So that would be moving something in a circular motion. And we're going to go over these again here in just a second. Pronation is this. It's palm down. Supination, palm up. Inversion is turning something inward. That would make sense because inversion, so inversion, eversion. Dorsiflexion and plantar flexion, I will show you along with these two. I went over that. All right. You are going to do these movements on yourself for right now. Usually I have you. Do I want you to have a partner? Yeah, I want you to have a partner. But I want you to sanitize your hands, I guess. I don't know what else to do there. COVID has got me screwed up with my class. Okay. So I want you to get a partner. Emily and Abby, you're going to be partners, and you're going to be in front of the camera. Okay. All right. So get with a partner. Label yourself 1 or 2. If you're a 1, I want you behind the patient first. Go sanitize your hands, everyone.
Is this gonna be hard?
No.
Okay, I was gonna say I don't want to make
Just a
myself
lot
look
of
like
terms.
a fool for doing something wrong.
Ben, will you bring that chair up here for me?
Which one?
What?
One of these?
Yeah, just one of them. Okay.
I wonder if I know anybody in your virtual class.
I don't know. You can wave to them.
Sean's dad is over here.
What?
Steven Souls.
Just smack you with the chair.
31.
Well, no, that might feel bad.
You'll be one or two.
I'll be two.
Two's the first loser.
Well, I don't know what one is.
I don't either.
I'm so
What is this max thing? Yeah, I saw the reminder.
Oh, I'll
of
talk to you about that. I'm trying to make it to where I can
Isn't it TikTok?
Yes. That's what's stuck in my head. But
share like more.
and he's just like,
Oh, there we go.
it's.
No, I wish I could make TikToks like Chloe.
Oh, perfect.
She's so clever. I love her so much.
She's in the chair. Do I see her?
Yeah.
Okay.
So right here. All right. You're going on YouTube.
Okay.
All right. You stand behind the patient.
Yes, sir.
All right. So I want you to stand behind your patient if you're a 1.
I wonder if I know it.
Ben, do you not have a patient? Come
I
over here.
almost remember I
Bring
went to
your
that
chair.
Are we sitting down?
So the patient needs to be sitting. Now it's going to be a little harder because you all are in test. So you all are going to do this as I do. Okay. All right. Now Ben, sit sideways. And then scoot to where you're. Okay. All right. All right. So okay, we're going to go literally head to toe. Okay. You have to tell me the movement, the name of the movement, as you're doing it. Did you all do this in therapeutics? No. Okay. All right. So first of all, take your hands, and they're going to be on either side. So, okay. Yeah. How you doing, Ben? All right. So first thing is flexion. So flexion, extension is back up, hyperextension is back, and then you're going to go back to normal. And then we have rotation, so side to side. This is doing it for me.
It's not obvious.
And then you're going to do lateral flexion. So that's actually like this.
That feels good.
Okay? That's the neck. That's it. All right? Flexion, extension, hyperextension, rotation, and lateral flexion. Okay? Where is your next joint?
Snap at your shoulder.
Your shoulder, okay? So you want to have one hand on the top of the limb, one hand on the bottom. You want to support it. A lot of you, I see, like you just hold their, I mean, what if the person's paralyzed, right? I mean, you can't just hold it like this. So those of you who are a patient, I want you to kind of be dead weight, okay? I want you to be dead weight, okay? So, except for you.
Yeah, I guess one left right here.
Because I don't want to have to work that hard. All right? Now, so put your arm down. So, first of all, we're going to do abduction. So, abduction, adduction, flexion is up, extension is down,
Oh, damn.
and then,
Wait. I'm confused.
okay, flexion is straight up like this. Flexion, extension, and then we can't do hyperextension back. I can't because I have okay? So next shoulder.
That feels good.
Now, what's your next joint? This.
That.
Your elbow. Your elbow. Okay, so I'm dead weight. This arm.
Yeah, 'cause this is
I guess. Oh. His arm dead.
All right,
I
so
mean, you could use this.
I got this thing. Like this.
oh, I'll do this one. All right, so flexion, extension, pronation is palm down, supination is palm up.
I can't see my
Okay.
face.
Now we're
I
gonna
know, this is
start
not
over
very
here in a
camera
minute, but
angle.
I want to get it to where they have an idea.
We're
Now,
gonna scoot
what's
back
your
so you guys
next
can see
joint?
us.
It's no.
Oh.
It's so bright.
What? Wrist, yeah.
Sleeping every
Okay, so
single
now you got
night.
your wrist. So out like this is where you want to start, just neutral. So flexion, extension, hyperextension, back down. Now, your thumb side, this is your radial bone, right? On your thumb side, your radius. This is your ulna. So if I move the wrist toward the thumb, that is called radial deviation. And if I move it toward the ulna deviation. Right? What's the next joint? Your fingers. Okay, I'm going to show you this one. Fingers and toes are the same. I am not going to make you do each other's toes. Okay? But here's what you would do. Flexion, extension, abduction, adduction, and then we have something called opposition, where you touch each thumb. Now remember, if they're paralyzed, can they do this? No, you have to do it for them. You have to do it. Okay? All right. That's the upper part. We're not going to do, what time is it?
We should trade in then.
I think we should do the neck again because it felt real good.
It's 1:30.
Okay. So we're going to stop this.
Was that recording the whole time?
Yes.
Oh, so no one is watching. Like live watching. No one's watching right now.
No one's live,
I was waiting. We were literally like, hey.
but I don't know how to stop it. Oh,